So my name is Orla Hardiman. I'm Professor of Neurology in Trinity College. I'm a consultant neurologist at Beaumont Hospital, and I'm the clinical lead in neurology within the HSE. Hidden symptoms are symptoms that people have that maybe they don't realise they have, or that they don't think that they're as important as they should be, or as important to allow them to bring those symptoms to their doctor or to their neurologist or to their MS specialist nurse. Well, MS is a neurological condition, and the nervous system, as you know, is very complicated. And so there are many aspects of MS that affect people's quality of life. I suppose the biggest ones that people often don't present with or don't like to discuss would be fatigue. That's a very disabling and debilitating part of MS, and people think, oh, it's just a bit of tiredness, and I know my doctor isn't really interested in that. But about 90% of people will suffer from fatigue, and it really impacts on their life. A second one is sexual dysfunction. It's really common in MS, and people are often very reluctant to bring those symptoms to their doctor. And of course we can treat sexual dysfunction in MS. It's something that really we should talk about openly. It's very important. Pain is another very common symptom in MS, and people often don't present with pain. Sometimes, of course, pain is from something else, and so we need to be able to dissect out the differences between MS pain and other types of pain. Cognitive change is very common, just a little bit of slowing down in thinking speed, and that can cause great difficulties, particularly in people who may have been functioning at a very high level and have just had a little loss which has had a catastrophic impact on their ability to work. It's really important actually that part of MS that is recognised and discussed, because we need to educate, for example, the insurance companies about the importance of this part of MS, because it may actually affect people's ability to work. People may have to stop working because of these symptoms. Other symptoms would be the sometimes people get a bit of a cold or a bit of a fever, and everything gets worse. And people think it's a relapse. So recognising the difference between what we call a pseudo-relapse, a relapse that's just due to a high temperature, and a relapse that is a real increase in activity of the MS and a loss of neurological function, and being able to separate those two out so we don't end up treating people who have a pseudo-relapse with steroids, because obviously long-term use of steroids are bad for you. Hidden symptoms sometimes are almost more important to report than symptoms that are visible, because as doctors we rely on what people tell us, and we rely on their neurological examination. So we can identify things like increased stiffness and slowing of walking and a little bit of impairment of coordination. So for example, if somebody tells me that they can't fasten their coat anymore, I can see that their coordination is giving trouble. If somebody's telling me that they're falling, I can examine them and identify the reasons why they might be falling. They might have a little bit more spasticity or a little bit more weakness. But hidden symptoms by definition are hidden. They're not things that are easily elicitable by us as doctors, and we rely on people telling us about those symptoms and making them aware of the importance. And as I said, the symptoms I think that are probably most incapacitating would be things like fatigue, which again, it's very difficult sometimes to describe fatigue. It's not just being tired. Fatigue is really a neurological symptom that saps people's energy. And cognitive change, often that's very difficult to measure. If somebody seems to be functioning fairly well on a day-to-day basis, sometimes that little bit of slowing down, that little bit of behavioural change that maybe a family member might notice may not be apparent to us as doctors in a one-on-one interaction that just lasts for a short period of time. And of course the other one is sexual dysfunction. Obviously we wouldn't see that unless we ask for it or ask about it, or the person is aware that is likely to be related to their MS. We can't really treat that. We have to educate our doctors as well about that. I think it's important to contact the healthcare team if the hidden symptom is impacting on quality of life. So it's really important, because it is important that even if somebody has MS, that they should live a full and active life and have as good a quality of life as anybody else. So things that are interfering with the ability to engage in activities of daily living or being happy are things that we should be able to address. Depends, when a hidden symptom occurs, it depends a little bit on what the symptom is and the impact it is having, whether it's a symptom that could be addressed by a GP or healthcare professional. Often the people who are most knowledgeable about this would be the MS nurses, because they see the real life effect of the condition, and they accrue a huge amount of knowledge about what it's like to be living with MS. So often they're a really good conduit between the GP, the system, and the clinical service provided by the neurologist. So I would suggest perhaps that the best person to discuss hidden symptoms with would be an experienced multiple sclerosis nurse, if the person has access to one. Of course, that's not the case across the country as of yet. We have to increase the number of MS nurses that are available to people, so everybody will have somebody that they can ask. In the absence of an MS nurse, most GPs are extremely well educated and very knowledgeable, and if they don't have a huge experience of MS, they can make referrals to the neurological services. I think hidden symptoms are often very difficult to communicate for exactly that reason, because they're hidden. So somebody may look really well, maybe walking very well and talking very well, and their MS is there in the background, but it's having a very major effect on their ability to live well. And I think the two major symptoms that come to mind in that regard are fatigue and pain. So I think it's very important that we communicate as professionals and as people who know about MS the impact of these types of symptoms, and the fact that they are part of the condition. The person isn't just giving in, the person isn't just being a wuss, they're not just falling under the fact that they have MS. These are very real symptoms and they have a very real effect. So understanding that MS is what we call the sort of generalized symptoms that are associated with MS, because MS is a neurological problem, but it's also an immunological problem. And sometimes when the MS is a little bit active, a lot of the chemicals that are released within the immune system affect our energy levels and our ability to function. And it's very important that we make that very clear to people who have the condition, to people around them, that this is something that's a real biological process that's going on, and not something that the person is just giving into, or that they're being weak. These are very real symptoms. The difference between tiredness that we all get and MS-related fatigue is actually often quite hard to parse out, particularly because MS-related fatigue has many different aspects to it. So I think trying to dissect out, what are the drivers for the fatigue? Does sleep help the fatigue? We know that sometimes sleep disruption is a feature of MS, and that there's a relationship between MS and, for example, narcolepsy. There's a little bit more narcolepsy in people who have MS. That can be important. I like to make the analogy of energy in the bank. And in MS, your store of energy in the bank is a little bit less than people who don't have MS. So if you're going to spend that energy, you have to build it up in advance, and then you have to pay it back afterwards. And I think that that's different from just being the normal tired because you've worked very hard during the day, or because you've done a 5-mile run. That the fatigue that occurs at MS is more consuming. Sometimes it doesn't really respond that well to resting. Sometimes it's kind of there all the time, and sometimes it just does impair people in their ability to do anything at all. And sometimes that's something that we need to recognise and try and manage and build into the day the fact that it's just not possible to do as much as somebody might be able to do because the stores are so low. So MS is a complex immunological and neurological disease, and everybody's MS is different. There are patterns of MS that we can see, and we divide MS into relapsing remitting MS and then a little bit more progressive. But the impact that has on people will differ widely depending on the activity of the disease and where the areas of inflammation in the brain are happening. So, and some people have very active disease, and sometimes some people have disease that isn't active at all. And we also know that the drugs don't work the same in everybody. Some drugs work in some people, other drugs work in other people. We don't really understand the reason for that, but that means that everybody's experience of MS is different, and we need to recognise that. Life is a terminal condition. So MS nowadays doesn't really shorten people's life expectancy, and in fact people who are diagnosed with MS now have a very, very good outlook, because there's been such a development in new medications that not only is MS not a terminal condition anymore, it should be a condition for which there isn't a huge amount of disability projected for the future. The myth that everybody will end up in a wheelchair is I find that it's one of the things that annoys me most, because there's three parts of that are wrong. One is everybody, the second end up, and the third is wheelchair. So first of all, everybody is different, so everybody will have a different experience. End up is dreadfully pejorative, because if somebody needs to use some kind of mobility device, it's an enabling, not a disabling tool. So ending up in a wheelchair implies that the use of a device is negative, and it's not, it's positive. The third point is, the implication is that everybody will be so disabled that they'll need a mobility device. Is also wrong. That's just completely wrong. That's not true at all. The vast majority of people with MS nowadays will have a full and fulfilling life, and I expect within the next 5 to 10 years we'll have treatments for the secondary progressive form of MS, maybe even sooner than that. We have one treatment already for secondary progressive MS that's going through the processes of licensing now. So it's not that far away before MS will be a completely treatable disease. So the idea that people who are diagnosed now or diagnosed within the last 5 to 10 years will be so disabled that they won't be able to mobilise independently, that's just wrong. The idea that if you've been diagnosed with MS that you'll have to give up your job is nonsense. It is the case sometimes that people may have to change their jobs for a variety of reasons if they've been diagnosed with MS, depending on where the maximum part of the brain that has been affected by the MS, depending on the part of the brain that's been affected by MS rather. And so sometimes, if somebody was engaging in some kind of work where they needed real precision hand function, and their hands were a little bit weak or a little bit unsteady, clearly they'd have to change a job. A brain surgeon who had a tremor, for example, wouldn't be a very good brain surgeon. So sometimes people might have to adjust what they do, but in general, the decision to continue to work or not to continue to work, or the decision to continue to work in the same sort of job that the person has, should be made very carefully, and there's no reason to believe in the vast majority of cases that you have to change your job or give up your job. The issue about people with MS, whether people with MS can have children or not, we have to divide that out into who has the children and who doesn't. So women have children and men make children. When I was starting in neurology, the advice was for women with MS not to have children, and it was completely wrong advice. There is really no reason why if somebody's been diagnosed, if a woman has been diagnosed with MS, that she shouldn't be able to plan a family. There are, of course, some concerns around that, because the drugs that we use for MS, by and large, with one exception, we don't recommend that they're used in pregnancy. They're contraindicated in pregnancy. So with one drug exception, people come off their medications when they become pregnant. But it's also the case that pregnancy, by and large, dampens down the immune system, and therefore the risk of having a relapse during pregnancy is actually reduced. Now the risk of a relapse after the baby is born is increased a little bit, but that's very manageable. So we don't advise people anymore that they shouldn't have children. There is a registry of pregnancy and MS, so people have looked at this, and the consensus view is that it's not appropriate to tell people, women, that they can't get pregnant. For men, the same issue. Men with MS are often on medication, but I'm not aware of any literature at all that suggests that being on the medication for MS that we know about, the lysis medication, is injurious to men becoming fathers. So that's definitely a myth that we should bust straight away. If people have been diagnosed with MS and they want to have children, with some support from their neurologist, it's perfectly fine to go ahead and get pregnant.